Good day. My name is Reverend Gregory Holston, and again, welcome to Just Nation, a program dedicated to talk about issues of faith, justice, and race in the city of Philadelphia and beyond. And we're excited again to be here today to have this wonderful and powerful conversation around some of the cuts that are happening in the present administration around Medicaid. And so I'm here again with my co-host, Nia Holston. So glad that you're again with us.
Yes.
And so excited for this conversation today and all we want to talk about. So
Yeah, and I'm excited as well to talk about it, but I'm also, just the last several months, last several years, quite frankly, have been really difficult in terms of the volatility.
Yes.
Of the United States government and all of the changes that they've already made to entitlement programs that have already not been well funded, right? And so I think today's discussion is really, really important because it's important for us to know what's on the horizon and what could potentially happen, particularly around the issue of healthcare. So I am excited to be in discussion with the two of you. But
you should always be excited to be with your father.
But I am nervous and frightened for what's to come.
Yes.
But it is so important and critical that we talk about what's happening so people are aware and so we can figure out how to fight back.
The threats and the cuts that Trump is talking about is unprecedented. In this budget, $600 to $700 billion are being cut from Medicaid, where they're proposing as much cuts in the future of 2 to 2.5 trillion, that's trillion with a T, dollars cut out of this program. That's really going to do horrible things to the life and the health of many of us in this country. And all of us need to be aware of what those things are so that we can fight back and push back against these kind of cuts. And so that is kind of the context of what we're talking about here today, that we want to go really in depth in and understand completely, so it will move you to action, move you to actually doing some things that actually can push back and hopefully save this most important and major program in our country. So Nia, I'm turned over to you again to kind of introduce our guests and get us into the conversation.
Yeah. So I'd like to introduce you. Dr. Cheryl Bedigal is our guest for today. Dr. Cheryl Bedigal is a family physician by training, but also served as the former health commissioner for the city of Philadelphia. And Dr. Bedigal will have lots of insights to share about what Medicaid is, what the impacts of these cuts will be, and the importance of paying attention to what's going on in Congress, right? And so, Dr. Bedigal, if you can start with just talking about your background and how you came to this work.
Sure. So, as you know, I'm a family doctor. I went to med school. I was actually in a PhD program in anthropology, and one night in conversation with my then boyfriend, now my husband, who Reverend Holston knows, I realized that I wasn't doing what felt like the right work for me, that I wanted to be doing something that when I went to work, I knew that what I did that day mattered and made a difference for people. And that for me meant going to med school and meant working in the inner city for, at the time I thought 10 years. And then trying to do health policy and really try to fix that system. So that is fairly close to what I've done. I worked in the city health centers and got a firsthand view of just what injustice does to the human body and how much injustice we have in our society. I mean, one of the real privileges of being a doctor is getting to be in conversation with people about what their lives are like, and then having at least a little bit of power to make a difference. But that work also took me into advocacy for better access to care, and all of that work kind of fed into the work I did as health commissioner.
Yeah, and I do have a follow-up question on that. So you said you got to see what injustice does to the body. by working at the City Health Center. So can you describe some of that, maybe in reference to some of what we're going to be talking about today?
Sure. So, I started at the City Health Centers coming out of my residency in 1999. So at that point, that's well before the Medicaid expansion. Most of my patients in the City Health Centers were working often 2 jobs or 3 jobs. Some of them were also taking care of young children and elderly parents. They worked all the time. And many of them worked at jobs that not only did they not have health insurance today, but they would never have health insurance. You know, people who worked cleaning houses, people who worked in landscaping, people who worked as aides in our city schools, people who worked in security, like security guards. You know, you could go on. There's a whole categories of jobs in this country that just didn't offer health insurance. And so they were basically shut out of care. And the one thing they really understood very well about our healthcare system was that it's incredibly expensive. So they would avoid seeking care. And the data says this, like people who are uninsured, you know, in general tend to avoid care seeking because they would be charged these astronomical charges. And so, you know, I mean, there are so many people I remember, but the cases that just stick with me the most, you know, for example, a toddler who broke her arm on a Friday after the clinic closed. And it was a bad break and she was in horrible pain, but her parents didn't know what to do and they knew they couldn't afford an ER bill. And they brought her in on Monday. And just looking at the face of a child who has suffered for days because of our system, right? I mean, her parents knew that something was terribly wrong and they knew she needed care, but they didn't feel that they had a way of providing it.
And that must be very difficult for those parents, incredibly
difficult. Incredibly difficult. I mean, you know, at the other end of you know, sort of thinking about adults, I mean, I took care of a lot of people who worked as independent contractors and who had difficulty coming in and difficulty getting their meds because they didn't get paid time off, or they worked for employers who didn't give them paid time off. And so over time, you know, high blood pressure would go uncontrolled, and a lot of them developed kidney failure. Some of my diabetics went blind. You know, this is in Philadelphia. It's not like we don't have doctors in Philadelphia, but people didn't have a way of affording the care they needed. And so, you know, you would watch this happen. And, you know, or people would come in and the first visit they would have with the doctor was after a stroke. You know, whole left side of the body is paralyzed. Family is having to stay home with that person and attend to their needs because they're not safe at home. You know, there are stories and stories and stories, but that's where we were before the ACA.
Before the ACA, and what is the ACA?
So the Affordable Care Act, which passed in 2010, but the Medicaid expansion for Pennsylvania was 2014. And so there were multiple provisions of the Affordable Care Act, but one of the big ones was allowing Medicaid to be expanded to a series of groups, but including adults who are non-disabled. And that used to be a group of people who could not get coverage unless they could get it through work. Or unless they could pay some massive bill. And so for the first time, you know, a healthy working 32-year-old could have health insurance, could get cancer screening, could get control of chronic conditions, could get screened for chronic conditions.
I don't think I realized that aspect of it. I mean, I was in high school, early college when the Affordable Care Act, or Obamacare as some people know it, was passed. But I don't think I realized that literally my generation, I'm being impacted, and I was able to, in some ways, access care, you know, stay on my parents' health insurance till I was 26, access Medicaid myself when I was not working and when I was in school. All of those things, literally, I came of age when they happened.
And I think for a lot of people, you know, the idea that pre-existing conditions can't be used to jack up the cost of your insurance, or that preventive care should be free. You know, those are all in the Affordable Care Act, but we think of them as normal now.
Yes, we do, but I do remember the time before the ACA, as a pastor, members of the church who were dealing with all kinds of illnesses and sicknesses, and relatively young. I remember one who pretty much lost all of his teeth. Because he couldn't get any coverage. it is really barbaric that we allow, and there was roughly 25 to 30 million Americans that the ACA eventually covered, that they didn't get coverage, and would go and regularly work at jobs or whatever without coverage, and had jobs that didn't have insurance and didn't have coverage for their own children, on and on and on. And we thought this was perfectly fine in the 1990s.
Well, I'm sure you didn't. And
no,
you know.
I didn't, absolutely. Yeah. And there was certainly a movement of people trying to make change happen. But we kept, as a community, as a country, rejecting it. And everybody knows the battle of how hard it took getting Congress to pass the ACA, and for Obama basically used up all of his political capital making sure that that happened. And it certainly has made a difference in many people's lives.
And it wasn't what he wanted initially.
No, far from what he wanted.
Yeah, I mean, there were a lot of gives in that. But I also remember being in practice after it passed and after the Medicaid expansion, seeing people who had not seen a doctor in decades. And they would come in, you know, a woman who worked on a farm with these hands, you know, rheumatoid arthritis does horrible things if you don't treat it. I don't know, she was milking cows, I don't know how, because her hands were so deformed, but she got Medicaid. Another patient who's hyperthyroid, which does a number on your heart if you don't treat it, but is really treatable. But you have to be able to see a doctor. But all these people who came in, and you know, you'd ask them last medical visit, when I was a kid. And they were coming in, and we could actually take care of them.
Yeah, I mean, I'm getting emotional even just listening, you know, to you talk about it. And I'm sure, you know, living those experiences, you're also, you know, recalling them and getting emotional as well. There's just so much, you know, so much that's problematic about our healthcare system. You know, I'm a person who believes that healthcare is a human right, and you know, we know that other countries are doing this.
Yes, and been doing it for a very long time.
Right, right. We know that, and there are gross, perverse incentives that are keeping the system the way it is. But there were changes that were positive, that had real, tangible life impacts for so many people.
And I think before we kind of transition to talk a little bit about these Trump cuts and what they mean, to understand that our healthcare system, the reason we did not have healthcare for all, like so many other nations, really was around the issue of race. There was one particular author in 1896 who wrote a book about let's make sure we do not allow black people to have healthcare. So we don't want to have universal healthcare for everybody, because we don't want black people to have it. Because we want them to die out in a generation or two. This was the time of what's the phrase? Eugenics, as a really philosophical thinking that the elite in the country believed in deeply, and they believed that black people were inferior and therefore should not exist, and propagated that in the early 1900s of our country. And that's why every time Roosevelt, first Teddy, and then FDR brought up the idea of healthcare for all, it was voted down mainly by those in the South who did not want black people to have it. Same reason we got Social Security around, but we didn't get Social Security for domestic workers and other things, because black people were in those jobs. And so race is always a through line in so many of these things, that policy is created that is to hurt black people, but usually ends up hurting everybody. And I say all of that to kind of be mindful that even when we had the discussions with Clinton trying to do health care in the 90s, race was brought up as a part of that. And then, of course, the ACA. That's why it was called Obamacare. And people in Kentucky believing that it was only for black people. Yeah, and not, in fact, my good friend Mark Steer of the Pennsylvania Policy Center always tells me the story about the person in Kentucky who said, yeah, I'm glad that we didn't ever take that Obamacare. Our Kentucky care is so much better. not realizing it was Obamacare. You know?
Yeah, or we have the Affordable Care Act. We don't have Obamacare, right?
Yes, yes.
Right. I mean, there's so much here, and there's so much in what you just said. But I want to make sure that we're also defining terms as well. So we've talked a lot about Medicaid, but what specifically is Medicaid?
Oh, yeah, that's a great question. So, and I'm going to define it, but also talk a little bit about Medicare very briefly,
Yes,
because people
yes.
tend to mix them up.
Yes,
Yeah,
yes,
yeah,
please.
yeah.
So, in general, Medicaid is a publicly funded, federal, but managed by the states, health insurance program for people who are low income, in general. Medicare is a insurance program for everyone 65 and up, with a few exceptions, and for people with disabilities. Medicare doesn't kick in for people with disabilities for 2 years after they are officially disabled, which is one of those puzzles I have never been able to follow. You're too disabled to work, but not disabled enough to need health insurance. But so Medicaid covers people who are low income. About half of Medicaid dollars, though, pay for nursing home care for seniors. So it's not, most of those dollars are not necessarily strictly, it's nursing home care for people who are low income, but many of our seniors in this country, this is a whole other conversation, are low income. There are also people who have both Medicare and Medicaid. But in general, if we think of them in simple terms as Medicare for people who are older, Medicaid for people who are low income.
I have so many questions about that because, you know, when people talk about using Medicaid or using Medicare even, right? People don't think of that as a federal entitlement program. They think of, I paid into Medicare my entire life. This is, you know, what I deserve. And so the point that you're making, that some people have Medicaid and Medicare, particularly those who, you know, may have worked for quite a bit of time, and you know, those programs are keeping their children from going bankrupt. So if you could speak a little bit about that,
Yeah, I mean, you know, I think, frankly, that was part of the brilliance of the design of Medicare, was everybody felt like it was theirs. That's why it wasn't an entitlement program with income criteria. If it's for everybody, it's easier to get it passed. And that sense of I paid into it, it's not a handout, you know, I think has been important in the buy-in for Medicare, which is very, very strong. I mean, arguably, we all pay for Medicaid too, right? I mean, we pay our tax dollars. That's how Medicaid functions. If people are not making enough that they're paying taxes, they're working, right? And almost everybody who has Medicaid works. So, you know, maybe we should just see Medicaid as a small incremental way of paying people back for the fact that we're not paying them a living wage. But, you know, we pay taxes. That's where this comes from.
Are there any surprising ways that people who maybe are not considered like your stereotype version of low income are benefiting from Medicaid? Are there examples that you can give of that, of how maybe they don't identify as low income, but they may be benefiting, or their families may be benefiting?
Absolutely. I mean, you know, 2 out of 3 people have somebody in their lives who has Medicaid. So almost all of us are in some way connected to or benefiting from the program. You know, there are, for example, kids with disabilities often have private insurance, but Medicaid picks up the costs that their private plan doesn't pick up. So that's one obvious example. But if we kind of take it out to the big picture, anybody who lives in a rural area is benefiting from Medicaid. And arguably all of us are benefiting from Medicaid. And the reason I say that is that hospital margins, especially in rural areas, are very, very narrow. And so without Medicaid, many rural hospitals and some urban hospitals would probably close. And that means that people would be traveling much further to get care in an emergency. It also means that the emergency rooms at those remaining hospitals that stay open would be very, very full. We saw this during the pandemic. And for people who don't remember, one of the things that happened is people who came in with a heart attack or a stroke often waited days. And there were people who died in ERs waiting because
Yes, they did.
you can only see but so many people, and you can only triage but so fast. And if everybody has a true emergency, what are you going to do? So when we see rural hospitals close, if these cuts really come to pass, we are going to see a huge impact on rural America. And those are folks who really don't identify as benefiting from Medicaid. But those hospitals run on Medicaid dollars. So, yeah.
Would those hospitals also, the ones who survive, would their care be diminished because of the extra pressure?
So, we see this already in some situations, and certainly when we have a wave of infection, we see it. But when hospitals get overburdened, a lot of things happen. So the ER backs up, and that's the way most people see that most obviously. The wait times can be very, very long. Often people end up leaving without getting seen. But it continues on up. So, if nursing homes close, then you can't discharge patients to a nursing home. And if they're not okay to go home, you have to wait for a nursing home bed. You could be waiting weeks. So now that's a bed that's full. That means that person in the ER can't go up to the room, even if they need to be admitted. That means they're doing what we call boarding in the ER, which is not great medicine. It's really, the ER staff are, just this number of people they are. So you're trying to watch a person who you're not really still responsible for, but nobody is. So you're trying to watch that person. Then now you've got more and more and more people, but you can't get people up to the floor. And the other thing is just the suffering side of that. Imagine somebody who is sick enough that they need to be in the hospital, which is in today's America very sick. And now instead of being in a at least relatively peaceful room, they're in the ER. It's loud. There's a lot going on, and they are not getting any rest. And they might not be there, 12 hours or 14 hours. They might be there for days.
Wow. What kind of, in comparison to the rest of the world, what are we talking about in terms of what these cuts could possibly do?
We are talking about potentially destabilizing our healthcare system. And we've always prided ourselves on having the best healthcare in the world. But imagine a situation where Americans are driving an hour or more to get to a hospital and then waiting and not getting seen for very long periods of time, where many people just can't get care at all. And where by the time they get care, they've experienced all sorts of complications that were completely preventable. Our life expectancy is already substantially lower than most wealthy countries. Years lower.
Say that again. Give us a comparison of that. What countries and what is the age difference?
Well, at this point, we're lower than most countries in Europe and many countries in Asia, and those are countries that have life expectancies in the low 80s, whereas it's 78 in the U.S. But we dropped during the pandemic. And some of that was COVID, but some of it wasn't. Some of it was chronic conditions where people couldn't get care or they were afraid to get care. We could see a drop again. And if you look at the graph of life expectancy in other countries and the US, what you see is, a steady increase in other countries and the US just dropping off. So we haven't committed to having a healthy citizenry. And because of that, we're not making these investments. But this is a whole other layer of or level of chaos that would be very different from anywhere else in the world. And if you look already in parts of Philadelphia, our life expectancy in North Philly is comparable to Syria and Yemen already. And that's with the Medicaid expansion.
And how old is that?
It's about 64, 65. Yeah. It's years.
Yeah, wow. And you mentioned rural hospitals earlier, but presumably these Medicaid cuts would also impact a city like Philadelphia, which I read a statistic the other day. I think it was on a bus billboard or something like that, but it said that one out of the 6 doctors that are practicing in the U.S. are trained in Philadelphia. We're the city of eds and meds, right? Like we're the city that really prides itself on its medical care and its medical facilities. And yet, at the same time, you just said that Philadelphia's life expectancy is over a decade lower than the national average, which is much lower than the
Yes.
European average.
So that's parts of Philly, but overall in Philly, we're at 72.4 or so. So we
Okay.
are years less than the average. But yeah, I mean, you know, all of our hospitals operate on relatively narrow margins, some obviously narrower than others. And some hospitals in the city take care of more patients with Medicaid than others. These cuts put all of them in jeopardy. And you know, even if they're not in financial jeopardy of closing, there's those same issues of ER crowding, you know, unable to get people up to beds, unable to discharge to nursing homes that could happen here.
And then presumably asking questions that, you know, we wouldn't want to ask as a city. You know, we pride ourselves on not, you know, inquiring about immigration status or in hospitals, and I could foresee with some of these cuts that becoming something that happens. Is that correct?
Well, so the Medicaid cuts, EMTALA, unless there's something else that goes on, EMTALA requires that any patient who is unstable be admitted, be treated until they are stable.
What's EMTALA?
So the Emergency Medical Treatment and Authorization, and what does the L stand for? I was doing okay.
Okay, it's a law.
It's a law
It's a
that
law.
basically says that if somebody comes in to a hospital's ER and they are sick or injured, the hospital has the responsibility to treat and stabilize them. And they can't send them out until they are stable. Someday we'll look up EMTALA and find out what the L stands for.
You did pretty good on that, though.
I was doing well for a minute, right? The A is ACT, but so that law plus, you know, medical ethics means somebody comes in, we don't ask them questions about their citizenship. We treat them regardless of their insurance or lack thereof, or private or public or whatever it is. But there's a whole lot of administrators who need to keep the hospital doors open, so they have to figure out the rest. But the ER, you know, I mean, I don't frankly know what happens if if Trump tries to roll back EMTALA or tries to legislate requirements that we ask about immigration status in ERs. That's been litigated before. I'm talking to a lawyer, so I'm hesitant to go too
But
far
not
down
my
that
field.
road.
But not my field.
But at least the courts have said that they can't do that. Now, you know, we'll see.
Yeah.
Yeah. So you said a lot in this conversation. One, we talked a little bit about the history and part of it was about the ACA, and then we talked a little bit about the conditions today, even before these cuts. And quite frankly, it's kind of a revelation to me that we are that bad in terms of life expectancy. I guess I shouldn't have been thinking that way, but just to hear the numbers of 72 years for Philadelphia compared to the low 80s in countries around the world, and parts of Philadelphia as low as 64 years of age, that we're pretty bad now.
We're pretty bad now. I mean, healthcare is only a fraction of that.
Yeah, but our system itself, which we spend more money than anybody else,
Far.
is not a good system
Right.
compared to the other countries in the world.
Right.
And now we have this assault where billions and probably trillions of dollars will be taken out of Medicaid. Can we even begin to speculate what that might do to the life expectancy if we're already talking as little as 64 years of age in some parts of Philadelphia? What these cuts could possibly add or subtract to those numbers?
I mean, you know, somewhere upwards of 650,000 Philadelphians currently have Medicaid. And we're estimating at least 100,000 could lose it. And that's on top of about 100,000 people who lost it in what people refer to as the Medicaid unwinding. I really hate that term because it sounds benign and it isn't. But when the pandemic was officially said to have come to an end and continuous enrollment was stopped. Because, you know, one of the things about, I feel ridiculous saying this to the two of you who are such experts in this area, but one of the things about being poor is that many people living in poverty in our city don't read that well or have that much time. I mentioned 2 jobs, 3 jobs, caregiving, et cetera.
Absolutely.
When they get a letter from Medicaid, you know, multiple pages of single-spaced print, they don't always read it. They can't always read it. And so people, every time we ask people to renew, we lose people. So when we had continuous enrollment, we didn't lose people because we didn't dump them off Medicaid if they didn't fill out the form, which they maybe couldn't read. Or, you know, a lot of my patients would say they didn't reliably get their mail, which is, you know.
Yeah.
But so we know that when we make people renew multiple times a year, we're going to lose people.
And so I even, just as an aside, I mean, sometimes it's difficult for me when I get mail. I get overwhelmed, and you know, knowing how to respond when I have so many other pressing needs in life, it's difficult, right? It's difficult for anybody. But I think your point is certainly well taken. That it's, you know, this is the intended effect of these cuts, to push people off Medicaid. So no matter what a legislator may say, that this is not kicking people off of Medicaid, this is not reducing Medicaid, that is the intended effect. And so I think we should maybe transition to talking about some of the policies that are being legislated right now. Trump has indicated that he wants to pass an enormous bill that contains a lot of different provisions, including making some of his tax cuts that mostly benefited wealthy people in the U.S. From 2017. He wants to make those tax cuts permanent. And to do that, he has to take money from somewhere. To give money to the rich, he has to take money from somewhere. And so he has a bill that he would like to pass called the One Big Beautiful Bill.
Please don't use the metaphor. There's nothing beautiful about
this
bill.
There's nothing beautiful about this
all.
bill. But in short term, it is literally taking from the poor to give to the rich.
Absolutely.
And
reverse Robin Hood, as we like to say.
Yes, and that is not an overstatement. That is just a fact. That is a fact. And so, Dr. Bedegal, if you can talk a little bit about some of the cuts that are included in the bill, or the cuts, or you know, the changes to Medicaid or the changes to healthcare that are included in that bill.
And when you do that, I want to come back to those numbers around how many Philadelphians are actually losing because of this.
Okay. So, I mean, you know, there's quite a lot in that bill. But, you know, to give you an example, the work requirements, these have been tried in Arkansas and Georgia. They were a disaster. Among other things, they were expensive.
And the work requirements for Medicaid specifically.
Yes. So this is the idea that people who have Medicaid coverage should certify once a month that they are working a certain number of hours. Most people who have Medicaid do work. The big motivation for working being needing to earn a living and eat and pay rent. But there's only something like 6% of people that are either who are not working and also not in school and not caregivers and would actually be eligible. So it's kind of making things up. But we've seen that this is really expensive for states to implement, like tens of millions of dollars of expensive per state. It does not result in anybody, in more people working, but it does result in huge loss of people on Medicaid. And so, you know, that's one thing that we can expect, as if that gets passed, there will be fewer people with Medicaid coverage. Nobody else working, and because nobody else will be working, also they won't be earning more, so there's no more taxes to be paid, but we have these costs on the states.
Was that calculated to the number you said, 100,000? There are going to be 100,000 lost here in Philadelphia.
This is a very rough estimate, and I am worried that it might be significantly larger.
Okay.
But it's, you know, it's
but that's one of the tactics that will push people
off.
Is
the work requirements. And then there's this requirement to renew every 6 months for everybody. We have, for example, in Pennsylvania, when a woman or somebody who's pregnant gives birth, they stay on Medicaid for a full 12 months. So we wouldn't be able to do that. Our children, this is one of the things I used to see all the time at the health centers. Young children would lose their Medicaid because they were up for renewal, and maybe, a lot of our families are kind of transient. If they're dealing with eviction, they're dealing with all sorts of things with landlords, they may not get the notice, or they may not be able to read the notice, as we discussed. So now they've lost their Medicaid. Now they have to renew, but in the meantime, maybe something happens. And either the parents don't seek care because they know they don't have coverage, or they do seek care and now they have a huge bill. And one of the things we have had, which has been useful, is a 90-day back, like the ability to cover 90 days back. So for example, a child goes to the ER, gets seen but was uninsured, they get a huge bill. Now we can renew the insurance and it would cover that bill. But we may not be able to do that with the cuts. That's actually huge for families. Because one of the nice is the wrong word, but one of the evil features of our healthcare system is that we charge people who don't have insurance an order of magnitude or more than we charge people who do have insurance, because healthcare providers, like the institutions, work out payment arrangements with insurers so they pay a fraction. Which means that, for example, I had a patient years ago who got a bill for a colonoscopy of $6,000, and that was many years ago. I mean, these ER bills can be immense. Hospitalization bills can be unbelievable, and even just a specialist visit, if somebody needs one, it could be in the thousands. So, all of those things, and then the other thing, we keep hearing from the administration, we're not cutting anybody's Medicaid. But what we think is going to happen is this combination of factors such that many people lose their coverage, but also there may be cuts in what's covered or how much they pay providers of various sorts, which may mean there's fewer providers accepting Medicaid. There's lots of ways this can happen.
Explain that a little bit more about the acceptance of Medicaid by doctors.
Yeah, so Medicaid tends to pay substantially less than other insurance. And so we already have a problem in Philadelphia. This was mapped out maybe 5 years ago, that there are parts of our city where it can be difficult for somebody who has Medicaid to get seen. The exception to that has been our federally qualified health centers, our city health centers, which get an enhanced rate. They get paid more if they see a patient with Medicaid, and the reason for that is they provide a whole range of wraparound services for that person. One, our community health centers, federally qualified health centers, are definitely at risk because if Medicaid reimbursement drops or fewer people have Medicaid, they may not have the revenue to stay open. That's part of how they see people who don't have insurance. So that's part of our safety net and how our safety net operates. But also something as simple as patient needs to see a specialist. Maybe there isn't a specialist in that part of the city who accepts Medicaid, or maybe the few people who are seeing patients with Medicaid, the next available might be 6 months or 9 months off. So it's all sorts of parts of this that will not function.
And more burdens on other institutions, right? So I'm thinking, and particularly in my work, right? So if you're incarcerated, if you are incarcerated, you're not actually eligible to use Medicaid for your health care while you are incarcerated. And so that means the state is paying for that. It's my understanding now, please correct me if I'm wrong, that the state may retain your Medicaid number, and that upon release, you can then utilize your Medicaid. And so if people are being kicked on and off the rolls periodically, they may not have that same Medicaid number to reapply and then get services in a timely fashion once they're released.
Yeah, so this is also, that's another new thing. I don't think that was the Affordable Care Act, but sometime within the last 10 years, it became possible for people to get Medicaid that would kick in as they left prison, that would reactivate. It used to be that they were not eligible for Medicaid.
Okay.
So one of the things we used to see a lot was somebody would be released from the prison, they would need antipsychotics, which we want them to have, right?
Yes,
this
we
is
do.
part of how they ended up in prison in the first place, was not having those. And they wouldn't have a way of paying for them or for the psychiatric visit they needed.
Not to mention not being established with care, not having a
Right.
regular care provider,
Right.
just leaving the facility.
Yeah.
I think in Philadelphia, at least the policy from a couple of years ago was to provide people with 3 days worth of medications.
Right.
But certainly 3 days is not enough to
Yeah.
get established with a primary care provider if you didn't have one already, or and get access to the specialist that you might need. So it's already difficult,
Right.
but this would make it even more difficult
Yeah.
for people who are incarcerated or otherwise transient, right? Like we're not just talking about people who are low income. We're also talking about people who are unhoused. We're talking about people who may not consider themselves unhoused, but are, moving back and forth
Yeah.
between different houses, right? In different areas. So we're talking about so many people, and I think one of the parts of the genius of the robber barons in this country is that they're
the wickedness.
the wickedness, the evil genius,
Evil genius, yes.
of robber barons in this country is that they're able to pit everyone else against each other rather
Yeah.
than pitting them against the people who are the real
Yeah.
culprits of the problems in these institutions.
So to follow up on that point, the more broader piece is, what is the effect on people's ability to get the medications they need?
Right. I mean, medications are another piece of our healthcare system that is incredibly expensive. And that varies a lot depending what coverage you have. There's this, again, this is another whole conversation, but PBMs that manage meds but sometimes drive prices way up. Our healthcare system is dysfunctional in many, many, many ways. But the simple answer is, for many people who have chronic conditions, which is most adults in our country, high blood pressure, diabetes, asthma, the cost of medications without coverage, even if you're going with the lowest cost option, is often in the hundreds.
Yes, yes.
So, like the lowest cost version of a blood pressure medicine might be $30, but maybe you need another medicine that's 10, so now we're up to 40, and maybe you need an inhaler and you can get that for 35, we're up to, it just escalates very, very quickly.
And the cuts in Medicaid?
Well, so with Medicaid, those medications are covered, and often with very, very low copays. Without Medicaid, I mean, firstly, you need the prescription, right? But even if you manage to go somewhere and get the prescription, you may not be able to get the medication itself.
So when we talk about hundreds of thousands of people, maybe more, off of Medicaid, we're talking also not just their ability to be able to use the hospital, to be able to see a doctor, the ability to be able to get the medicines they need. That could be the difference between life or death.
Yes, and we are also talking about their ability to work and support their families. This is our everything.
Yes.
And I feel like it's going to be really, really difficult to reconstruct these systems if the whole thing falls apart. Hospital closes, it's not reopening. A federally qualified health center closes, it's probably not reopening either. And rebuilding those things is years of work. So there's the damage to humans, there's the damage to our social fabric, and then there's just our institutions that may not withstand this.
Yeah, I mean, this is a really, really informative discussion, and really difficult discussion as well. I also have questions, and I'm sure some of our viewers do, about how the changes in the Department of Health and Human Services and the Centers for Disease Control and Prevention, that's the acronym, right? Prevention is a part of it, right?
Used to be.
Used to be, right? How those changes enacted by their current director, Robert F. Kennedy Jr., can't resist shading him. I mean, no medical background whatsoever.
None
Definition
whatsoever.
of a mediocre white man, but that's neither here nor there. How those changes will impact overall care?
Yeah, I mean, this is huge, right? The CDC has been an international source of trusted information, trusted research, and essentially it isn't. You know, when information comes out of the CDC, it used to be our first go-to. So, you know, we want information about X condition. Look on the CDC site, because you can trust what they put out. But now you can't. So do you look and maybe try to guess if it's trustworthy? Or do you just, you know, and we are seeing some academic centers step up. And, you know, like pandemic tracking is no longer a CDC function. It's happening out of Hopkins, it's happening out of Brown, it's happening out of our academic institutions, which are themselves under siege. But so that role of trusted information provider, and the loss of that as a central thing for the country is huge. You know, the CDC historically has funded a lot of programmatic work in health departments to reduce chronic conditions, to ensure that we are prepared for public health emergencies. Not clear if that will continue. You know, CMS, which is the Center for Medicare and Medicaid Services, which is sort of what we've been talking about through this conversation, also part of HHS. I mean, you know, the just fundamental shift from a science-based institution to essentially political hacks, with some dedicated public servants still there trying to, as much as they can, make things function. I mean, it is a disaster. And of course, the death knell of American science, which has led the world.
And even the discussion about vaccines and, you know, all of the confusion stemming from that. I mean, it is really, that will impact all of us, even if you choose to get your vaccines or your vaccinations along the regular schedule. You know, vaccinations are like, it's like a boat, right? You know, you know, we all have to, you know, float together, like it'll sink. And so, you know, that is certainly, you know, very scary.
And you know, I think there's the cost factor, because those approvals of vaccines through ACIP and CDC drive insurance coverage. And also just the risk to us as a population. And we saw this with the measles outbreak in 2024. If people don't kind of keep the social compact, which is really what vaccination is. It's like your boat that you're talking about. I can't just keep my end of the boat dry and put the water in your end of the boat, or the boat is tipping. Measles, you know, we're seeing this huge outbreak. We don't vaccinate kids under a year typically. In an outbreak, we can give it under 6 months, but we don't usually vaccinate under a year, which means the mom taking her baby to Costco, that baby's at risk if somebody walks through. And measles is that contagious. And you know, we're seeing about 20% of the kids end up in the hospital with it. So it's just a devastating thing, and it feels like it's also part of our social compact falling apart.
So I think I also heard about, well, some potential polio outbreaks and stuff like that, that we thought we had that completely under control.
Yeah, so we haven't seen polio in Philadelphia. New York had a case. But you know, if we don't vaccinate our kids, we will. There's international travel. There's still a few cases internationally. And polio is one of those things, this doesn't come up much because we have a really good vaccine that we've had for years. But only about 1% of polio cases are paralytic polio, what we think of as polio, which means that 99 out of 100 people who get infected with polio have a little diarrhea but don't feel bad. Which means they may be walking around. Now, we don't have that right now in Philadelphia, but if we don't keep up the vaccination schedule, we could. But there's other things that are just much more immediate. You know, we're seeing kids who don't ever get a tetanus shot. We're going to start seeing lockjaw. Pertussis, we're still seeing. I
haven't heard that word since I was a kid, basically.
Yeah, because we have a really good vaccine that everyone gets. But tetanus is a real thing, and it's, you know, it's an environmental thing. So, like, if we stop vaccinating kids against it, we will see lockjaw in this country, which is just nuts.
Well, I think, you know, there's so much that I want to say, but and so many different points I can take this. But what it seems like, I think what's most disappointing from a policy perspective, that these things are even being considered, is, our politicians failing in their responsibility to their constituents, to their to the people that elect them, to the people that live in their areas, right? We've seen. So we're filming this in June. So this is before any of the new legislation from the One Big Beautiful Bill, blah blah.
Please don't use beautiful. Please don't use beautiful. Please,
Yeah.
please.
Well, I'm trying to be technical. Has been enacted, and we certainly hope it won't be. So we don't know exactly what the future will hold. But just last week, there was a senator, Joni Ernst, who, in response to constituent questions of saying, these Medicaid cuts are going to impact me such that I will die if I don't receive this care. Her response was to say, well, we're all going to die someday, right? And so there's this idea that it's become easier for people to be completely separated from their neighbor, from their friend, from their family member, from themselves even, just in an effort to, do what they want, to give money to the rich, or to support a politician like Trump, or to, preserve their own, financial status, right? And so there's so many ways that we see this in so many different topics, right? Whether we're talking about immigration, whether we're talking about other issues as well. There's so many ways that we see this breaking of the social compact, a social compact that really didn't exist for some people to begin with, to be clear.
As she said a couple times, it was bad already.
Right.
This is just making it worse.
Yeah. Right.
I think it's very powerful what you said in that comment by that particular politician. People are going to die because of this.
Yeah. Yeah. And the idea that someone just doesn't care.
Or
feels emboldened enough to say that, because maybe they never cared in the first place, right? But the boldness with which that was stated, it's just another example of the ways in which we are failing in our relationships with each other.
So we have about 5 minutes left in the program, and I just wanted to cut you on a couple of things, and then give you an opportunity to talk about the kinds of policies or what we need to do to kind of push back. First, we kind of touched on this already, but the racial disparities of this seem to be clear. If you could just elaborate a little bit more, particularly around Philadelphia, how will it affect the Black community and nationwide?
Sure. I mean, I think we've seen in Philadelphia and nationally that any public health disaster hits the Black population hardest because of all the history of racism and injustice and inequity. And I think we'll see this here. Medicaid is covering our lowest income population, and in Philadelphia, that is our Black and Latino populations. And so that's, I've talked some about the sort of way in which we are all at risk, but it's very clear that Black and Latino Philadelphians are at more risk and will be hit first. And we have a history as a city of all the bad stuff, but also of being a place where people do rally around each other and support each other. Not always and not perfectly, but maybe more than is true nationally. And I think this is going to be a much bigger challenge than anything we've faced. And I say that, having led the health department through 3 years of COVID, but this could be substantially worse.
Yeah, I was told the Philadelphia Department of Health had about $1 billion that comes from Medicaid, or roughly $1 billion budget.
I think you're talking about behavioral health.
Behavioral health, okay.
Yeah. But yeah, the impact on mental health at a time that mental health is a huge issue. It's a huge issue for our kids.
Yes.
And a lot of our kids have coverage through CBH, which is Medicaid dollars. So what happens when we deny mental health care to our future?
Yeah, I mean, I think of people who are impacted by the criminal legal system, right? I think of people who, you know, I see in court when I'm advocating for someone, the judge is just ordering, go to treatment, go to this,
Right.
go to
Yes.
go to that, as if that is they can just wave a magic wand and those things can happen. And the reality is, even now, there aren't enough places for people, or people have already been to those places and they're not helpful for that individual's care. But even with these cuts, we'll see more and more of that. And so there will be, because there are inherent problems with the criminal legal system, just assuming that people can get these sorts of things or else they'll have to stay in jail, you know, that would also cause other problems with our other institutions as well.
Yes, and our schools as well. I was an
Yeah.
emotional support teacher for 7 years and often had to regulate, you know, kids in medication to make sure the medication was done appropriately. And if there's no Medicaid,
Right, then there's no medication.
no medication.
Yeah.
And I know some of those kids, without the
Yeah.
medication, they could not be in that environment.
Yeah.
They would be a danger to themselves and a danger to others, which would disrupt schools as we know it. So there's school effects. Therefore, since all of these kids who are without the proper medication are in our churches, in our mosques, in our neighborhoods, in our rec centers.
And we have a responsibility to each other. We have a
Yes.
responsibility to take care of each other.
And so the effects of all of these institutions by this safety net being destroyed and will affect all of these institutions and the very fabric of our communities. So in the last, I guess, 3 minutes we got left now, can we touch on a little bit about what you think we can do to push back against this, and then we'll share a little bit more as well.
Yeah, I mean, I think this, among other things, like we need to be talking about this. We need to be talking about how it's going to affect all of us.
Do you think cities can help pick this up in some way? Foundations, somebody?
I don't think that we remotely have the resources to make up for what the feds are talking about doing. I don't think the state has the resources. They've said as much. I don't think the city has the resources. You know, that said, if this happens, we're going to do what we do, right? We're going to do our best for each other. We're going to figure out what we can do. And I hope we're all going to vote. Because, you know, it feels like we just have to understand as a nation that we are all connected and all need to take care of each other. But until we get there, you know, we're going to put our heads down and get it done as well as we can. But, you know, there's just no way around the fact that this is serious harm being done to the American people.
Harm on top of harm.
Harm on
Yes.
top of harm.
Harm on top of harm. And so, I mean, as we close, if you can tell us about maybe something that's making you hopeful in this time, you know, in relation to your field, or, you know, some new understandings that people are coming to in terms of healthcare. I know it's a difficult time and a difficult question to ask, but we definitely want to leave people with some
A
hope.
little bit of hope. I mean, the one thing that's making me hopeful, you know, when these executive orders first started, a few of us who kind of work in safety net kinds of settings put our heads together and said, we're going to have to be ready, and created a little nonprofit with we're not really sure what it's going to do yet, which we named, we had about a minute to name it, so don't judge us, Philly Health Cares. And that group now has over 150 doctors and other healthcare providers who share information, share ideas, try to figure out what we can do together, and is growing. And is people who are committed to trying to make things better however they can.
Yeah, yeah.
So we have, we're getting ready to close. And so thank you so much, Doctor, for all the information you shared with us today. And thank you again, our co-host, Nia Holston, for all the information you shared as well. There is hope. There is hope. There is hope. It's hope as a person of faith in God, but there's also hope in ourselves as a community coming together. And even what you just mentioned, the doctors beginning to come together to share the information they have. We can win together. It's going to be hard, it's going to be difficult. We're going to speak to our senators and our congressmen and everybody involved, and we can win. Thank you again for being with us on Just Nation.
Thank you. Good night.